recording. So it's all yours, sir. I'll go into mute format.
Okay, so those who are present here will discuss some basic aspects of mitral stenosis. And before we go to the subject proper, first thing is that you can interrupt any time you want for any clarification rather than keeping it up to the end. Because if you are not clear from the very beginning, then you will not know what to hear. So you can interrupt any time for any clarification. That's all. But in any case, after every 10 to 15 minutes, I'll give you a break for any clarification. So you have to be very attentive in your sitting, and then you can ask anything during that period or so. Before we go to the subject proper, it will be worthwhile to share some slides which we already discussed before, that these are the revision slides. For example, we have already told you clinical information, but remember, a 2D echo is equally important because it gives you complete anatomic information, the size of the chamber, the thickness of the chamber, how are the walls, and it also gives you a semi-quantitative idea of severity, as we'll show you subsequently. So this is equally important, and the hemodynamic information, as you know, is given by a Doppler which records the velocity. So all three are interconnected and very important. So some of the important revision slides are, as I've been repeatedly told you before, any chamber subjected to prolonged pressure or volume overload increases in size. That all you know about the volume overload means aortic regurgitation, mitral, and all these things also. A 2D echo always gives a semi-quantitative idea of severity. So do not neglect the a 2D echo study. So these two are important points. Then, as we told you, that a modified Bernoulli equation says that the velocities are converted into gradients. And as you have been told before, a gradient is the difference of pressure between the two chambers. And that is 4 into velocity square. So that means if your velocity is right, you can get a right gradient, but if your velocities are wrong, your gradients will be wrong and all your report will be wrong. So that you should give a maximum importance to obtaining a right velocity, because on that depends upon the various problems. Now this I told you again, that any view you take, the apex is always pointing, the transducer is always pointing above downwards. This has got a bearing to the Doppler also. So you see this Parashar is long axis view, the transducer is pointing this side. You see the apical four chamber view, and as you know, I keep my LV on the left side. So again, the transducer is pointing downwards. In any view, you say this is important. And the same thing you can see in a Doppler. Say again, you see that you can see flow coming from the mitral wall will be parallel to the flow, which is ideal. But in a parasternal long axis view, you see the Doppler will be perpendicular and not a parallel. And the best results you get when you are parallel to the Doppler. So these are the advantages of knowing which is the Doppler, which side your transducer is pointing downwards. And again, we told you last time that in diastole, the chamber fills up and increases in diameter. The example we gave you was a balloon. If you fill up a balloon with air, it increases in size, that is diastole. So that whenever any chamber is filled up, that is diastole. And when you empty it, it is systole. If you remove the air from the balloon, it decreases in size. So that means increase in diastole, decrease in systole. And of course, when one chamber is in systole, other is in diastole, that we'll explain to you better later on. The flow is always from a high pressure to a low pressure chamber. It is usually not from a low pressure to a high pressure chamber. Again, an important basic thing. Again, for example, you see this is an apical four chamber view. You see Yeah. You see, the transducer is pointing above downwards. So that means when the blood is going toward the transducer, it is above the baseline. So this is the mitral wall. You should put a Doppler. It is going towards the transducer. Hence, your signal will be above the baseline. So this is known as a positive Doppler because the Doppler beam is parallel to the blood flow. Similarly, if you take a three-chamber view, the blood which is going from the LA to the LV comes out through the LVOT and aorta. So when it is coming out, it is against the transducer direction. So it should be a negative flow because it is positive, it is negative. Here you see that it is a negative flow. So this just tells you that is how to know which side the transducer pointing. Then again, in every stenotic lesion, you must have been told last week, you always planimeter a jet, and when you trace a jet, it always gives you peak, mean, and the VTI. So that is a basic of all valvular lesion. That if you want a complete study, just trace this. So now we come. This also was shown last time also. Now, the sequence is always a 2D echo, color flow mapping, and Doppler. That will show you from the next slide. And again, I told you, try to get maximum velocities from a relevant scan planes. For example, some balls can be seen in multiple scan planes. So you have to check every scan plane which gives you a maximum velocity. That will be the relevant scan plane. Always see for an intercurrent illness in a valvular heart disease. For example, a patient developing a fever, any tachycardia, anemia, all these will affect your Doppler finding. So once those intercurrent problems are solved, then you repeat a Doppler or the echo study. But suppose you are not able to do that and write in your report that what was the heart rate and what was the blood pressure at the time of the study. These two are extremely important to record because the same thing will be done by another person after 6 months. So once you know that their finding may be different, you might have done at a heart rate of 65. He might be doing at a heart rate of 110. So the findings will be different. Same thing about BP. So always record heart rate and blood pressure. Always scan, always, and that is why ECG is the basic thing. Never do an echo without an ECG and then scan all balls. So these are some of the basic mantras also. So you this also you know I told you last time. You start with a two-dimensional echo. It gives you an anatomical and functional information. That what are the anatomy, what are the functions. Then the basic thing in a Doppler is to be parallel to the flow. So every study, whether it's a valvular heart disease or any echo, to this followed by a color flow mapping. This color flow mapping guides you parallel to the beam, and then you do a quantitation of the lesion, peak gradient and mean gradient in some cases, and calculation of wall area in every case. That is the important thing must have been told to you. Again, a B parallel to the flow. So this is why we always do from a 2D echo to a color flow mapping to a Doppler, because Doppler gives you more of a quantitative lesion. Now coming to the what we are going to discuss something about a few points about this pathophysiology. When we start with the medical, I'm just 1 minute. Yeah. So we always start with a pathophysiology of any disease or so, which is very important. Now you know mitral wall opens in diastole. This is already you know. So they allows the flow from LA to LV. Flow is maintained, and because the LA pressure is more than LV, because it is being filled by the pulmonary veins. The flow is maintained as long as LV pressure is lower than LA pressure. So once the LA is filling into the left ventricle, the LA pressure drops, the LV pressure increases. So when they are almost same or this, then the flow stops. Now what happens in mitral stenosis? There is a mechanical obstruction of the flow from LA to LV. So any chamber which is subjected to increase the pressure because of this stenosis, the LA pressure feels the brunt because LA is draining into LV. And when the valve is obstructed, then the LA pressure increases. It has to increase because LA is now emptying against an increased pressure. So as I told you, any chamber subjected to prolonged pressure increases in size, so there is increased LA size. So when the LA size increases, at some stage it can lead to atrial fibrillation and LA clot. So whenever you do an echo, basically besides all other things, see from the LA size, see for any LA clot which is present. There are two things. The LA pressure is again, the increased LA pressure is transmitted to the pulmonary veins because the pulmonary veins drain blood into the LA. So the increased pressure is transmitted to the pulmonary vein, and from the pulmonary vein it goes into the pulmonary artery, leading to pulmonary artery hypertension. So when there is a pulmonary artery hypertension, the RV has to eject against an increased pressure. So there is an RV overload and it increases in size and thickness. So that you also see for a pulmonary artery pressure, you see for an RV changes also. So this is the basic pathophysiology of mitral stenosis based mainly on an or clear. Okay. So after pathophysiology, we come to etiology. So that means up to pathophysiology, you are clear. Coming to etiology, now every etiology is primary, secondary, functional. In your case, it is rheumatic. In almost in about 97, 98% of cases, it is the rheumatic in our country. So that is the most common, and the basic thing is what is known as a commissural fusion is the predominant lesion. Just I'll tell you. So what I've written is live demo. There is no point in telling you in this lecture. So it will always be clear when a live demonstration is being done. So this the commissure is the place where, and this is short axis view. You see, this is anterior at the mitral wall level. This is anterior mitral leaflet. This is posterior mitral leaflet, and they join together at the commissures. So this commissural fusion is the hallmark of a mitral stenosis. So before they join the mitral annulus, the place where the anterior and the posterior leaflet join together is known as a commissure. And so it will be ideally to see you when a live demonstration is given. But remember, this is how a commissure looks like in a short axis view. And this is the place where you also see for a mitral wall area. Then you have the various other things which will be tell you just now, that the thickness and all this will tell you what are the findings just now. So a secondary or rather than just a minute. So besides commissural fusion, you see there is a thickening of the leaflets. This is the parasternal long axis view, aortic wall, anterior mitral leaflet, posterior mitral leaflet, left atrium. Left atrium is always posterior to the aorta in every scan view. And this is RV, so you can see a thickness of the mitral leaflet, a restricted opening, and we show you a paradoxical motion of the posterior cusp that will again show you. These are some of the signs beside the commissural fusion. Now, secondary, you can forget about it, but the what the normal we see every time is which is seen in this is once this was an 86-year-old lady, multiple comorbidities, very minimal physical activity, complaints of shortness of breath. This was attributed to age and multiple comorbidities also. But you see, the patient has a severe mitral annular calcification. This is LV, RV, LA, RA. This is the annulus to which the leaflets are attached. So you see they are highly calcified. And here also you can see a highly calcified a mitral annulus. So you see, and this annulus calcification can extend to the mitral leaflets and can produce a stenosis. This is most common in foreign countries. Again, you see, this is again a mitral annular this is the annulus, mitral annular calcification, and you see a turbulence. The most common is both, you can see both stenosis and this patient had a mean gradient of about 6 or 7. Just for you, because why I brought it, it is mostly seen in Western population. They don't see a rheumatic heart disease at this age, so their basic first diagnosis in these cases will be a degenerative mitral stenosis or a mitral annular calcification. This is because of effect of the increasing life expectancy, and mitral annular calcification is the commonest cause, and they have seen that as the age increases, the incidence of this condition goes up to 60%. Say 10% as increases 30 this. Of all cases of mitral stenosis, about 12.5% are because of a degenerative. So why I brought this slide is that occasionally you may get an elderly patient with this thing, and every mitral annular calcification should be studied that whether it is there or not. Although the treatment is very unsatisfactory, but you will see mostly rheumatic. But keep this in mind. Third is a functional. Functional is a transient hemodynamic mitral stenosis. By transient, we mean that there is something producing a transient hemodynamic mitral stenosis. Once you remove that factor, the mitral stenosis disappears. For example, see, this is a sort of a large fungal endocarditis. This is LA, this is LV, mitral wall. During diastole, it goes into the LV, and it will obstruct the mitral leaflet and produce a functional mitral stenosis. And when you remove this mass, it will disappear. So these are just a transient things or so. Again, you see, this is a LV, this is a left atrial myxoma. You see, during diastole, it goes into the LV through the mitral wall. So when it goes through the mitral wall, it may cause a partial obstruction to the mitral leaflet. So that is why we call it a transient functional stenosis. It is not a rheumatic, it is a permanent stenosis in treatment, but this is a functional tricuspid. It tends to disappear when the mass is removed. So these are some of the causes also. So you know basic pathophysiology, you know the etiology now. For you, it is mainly rheumatic, remember? And the diagnosis, of course, will already told you that every stenotic lesion, including mitral stenosis, is characterized by a thickness, fibrosis, and calcification. That is because of the basis of every disease, whether congenital or acquired, because of inflammation. That is a normal thing. Like any part of your body which gets injured, ultimately turns into a sort of a scar also. So this produces a thickening like this. Well, see, but the more important is the doming of the cusp in the direction of the flow. Doming means like you've seen a dome. When you see a dome anywhere, that is like a doming in which the central part protrudes, or also known as a reverse hockey stick. So I'll show you the convexity toward the distal chamber. So stenotic lesions are always characterized by a doming in the direction of the flow. To make it more clear, you see this is the left atrium, this is the left ventricle. The flow is going from LA to LV. So the doming is toward the LV. And you see, this is a complex, this is a sort of a, a dome-shaped anterior mitral leaflet, because it is why does this happen? Now, why this moves? The base is attached to the annulus. The tips are always thickened. The rheumatic process mostly starts from the tip of the leaflet, and so the tip cannot move, the base cannot move. So the only structure is moved in the mid body of the anterior mitral leaflet. So it is sign of mobility, but you see the convexity is towards the distal chamber. This is like a struck imaging. You see this LA, LB, and this is a doming. And another time, whenever you want to see a thickness of the wall, this is the ideal view, parasternal long axis view, and you see a doming, and at the tip of the leaflet, you can measure the thickness, which should be less than normal. More is more than about 4 to 5 millimeters. So this is like a doming, which looks like. Same, you look at aortic wall. The flow is going from, this is zoom the view. This is the interventricular septum. This is the mitral wall. This is the aorta. The flow is going from LA to LV to aorta. So the doming, you can see the doming or a convexity is toward the aorta. So when we say convexity, it is like a doming, it is toward the aorta because the flow is going from here. And this looks like this. So this is the doming of the aortic wall indicating a stenosis. You see, rather than opening like this, it is opening in a dome-shaped structure. Similarly, pulmonary stenosis, you see, the flow goes from RV to pulmonary artery. So you see at convexity, the convexity is towards a pulmonary artery, which is a distal chamber. So every stenotic wall we've shown has got a doming, and then you see, this is still view, the convexity is marked toward the pulmonary artery coming from the LA to RV to pulmonary arteries. Again, you see a doming, and again, you see a tricuspid wall. This is short axis view, RA, RV, part of this aorta, and you see this. The doming is toward right side. And you see there is a thickening of the leaflet, and because of a chamber subjected to increased pressure, right atrium is enlarged in size. So we have shown you a doming, and that why the doming is convexity toward the distal chamber is because of the flow in the direction which is going. So we have shown you a doming of all the walls. Now you see that this is a normal mitral wall. Now see, this is the M mode. This is normal mitral wall. This is the anterior leaflet and posterior leaflet. These are anterior leaf structure. These are posterior. The anterior leaflet moves in a M-shaped form. You see M, and the posterior leaflet moves in a W-shaped form. And they are, you see, it is M-shaped. It is M-shaped and it is W-shaped. And they are moving in opposite direction. And you know, when the mitral wall opens, I told you the mitral wall opens in diastole. This is all in diastole. You can see after the T wave. So that means when the mitral wall opens, there is a rapid flow into the LV, and that is produced as an E wave. This is known as rapid filling wave. This is normal individual. And when the LA mitral wall opens, the flow from the LA goes rapidly into the LB, producing a early wave, which is E wave. And then when the flow occurs, the LA pressure gradually decreases because it has emptied into the LV, and LV pressure increases because it has got the flow from the LA. So it partially closes. This is EF. So what is known as the EF slope, in every Doppler or every M mode, you'll find an A wave. A wave is the atrial contraction wave, which contributes to about 20 to 30% of the cardiac output. Then they close, and the CD is the closure light. So whenever you get this view, always see E is the opening rapid wave, EF is the closure point, deceleration time, and A wave is the atrial contraction, which comes with the P wave, and CD is the systolic wave. So these are the normal markings of the mitral valve. Now, what happens in mitral stenosis? Now, see, now you see the only thing important is the there are many signs, but if you are asked the one specific sign, that is the posterior leaflet moves toward the anterior leaflet known as the paradoxical motion. You see here, the posterior moves posterior, anterior moves anterior, anterior moves anterior, posterior moves posterior, and here you see they are moving towards each other. Besides the thickening, the all other signs can be found in other diseases, but the one important sign is the paradoxical motion of the posterior cusp. That is all. Just to take as we have seen at the tip of the mitral leaflet, we have put the M mode, and we get this. So this is the most important sign. Otherwise, most of this is just an incidental finding, just for you to understand that all that this is the most important finding. So beside this, as the wall narrows, the gradients increase. Gradients again a difference between the two chambers. Now you see, take this. There's always a feeding chamber. The increased pressure is always in the feeding chamber. In mitral stenosis, the feeding chamber is left atrium. Receiving is LV, so that the LA pressure is increased. In aortic stenosis, the feeding chamber is left ventricle. Receiving is aortal, so gradient is between LV and aorta. Tricuspid stenosis, the feeding lesion, the feeding chamber is RA, receiving is RB, so there is a gradient between RA and RB. Pulmonary stenosis, the feeding chamber is RB, receiving in RA. So that is why there is always a gradient between the feeding and the receiving chamber in all this. So as the wall will go on narrowing, the pressure will go on increasing and the gradient will go on increasing. So very simple thing to this. So the summary of the diagnosis is the thickening of the cusps. You see the thickening of the cusp, a doming of the anterior mitral leaflet, paradoxical motion of the posterior cusp, restricted opening, and chamber enlargement like LA enlargement. So these are the signs besides a commissural fusion. Any clarification at this stage? Any of you can ask. After unmuting yourself, if you have not understood anything, just now let me know.
Sir, while you have showed the parasternal long axis view, you have labeled them as E and A, but this is the anterior commissure. But for the posterior commissure, there
No,
is
no,
E F.
no, this I have told you the mitral opening. This was the mitral wall. This is
Yes, yes,
the
sir.
huh. If you
But
take a
the label
huh,
downstairs for the posterior is are the different because you have labeled
say,
it as E and A.
so the posterior will go posteriorly. So if in a short axis view, if you are taking this short axis view,
Sir,
yeah, if this is the commissure also, if you are taking a short axis view and see the mitral wall here, again you'll see the same thing. This anterior leaflet, posterior leaflet.
yes.
So what I have shown you is a M mode from a parasternal long axis view. The finding will be always be same whether you see from this view, wherever you can see this anterior leaflet, you will find the same finding right from apical or something. Anything.
Like
Anything. What? Huh?
but in your image, there is another level of EFC that I could not understand. I and
Eh?
yeah, the level there, see E and A is there at the same time. There are three other levels are there in the your image. Where parasternal long axis. M mode, M mode, M mode. Yes, F, C, D. I did not understand those
So
letters.
this is mitral opens in diastole or not?
Yes, yes.
Sure or not
Yes,
sure?
yes, sir.
So
Yes, sir. Yes,
when the mitral wall opens, the blood from LA goes to straight
हाँ
to
yes.
the gush goes to the LV, correct?
हाँ कुछ एक ऑनलाइन सेशन अटेंड कर रहा था मैं
yes,
हाँ
sir. Yes, sir.
That is known as an E wave. This is known as a rapid filling wave,
है ना
correct?
वो दिखा दिया
Yes, sir.
E wave
Yes,
is
sir.
a rapid filling wave.
हाँ
So
हाँ
when the LA is pushing blood into the LV, the
अच्छा
LA pressure goes down now or not because it is now emptying itself, correct?
है ना
Yes, yes,
And
yes.
LV pressure increases because it is
बढ़िया
now getting blood from LA.
Hmm.
At one stage, they come into equilibrium and the bomb tries to close properly. So this is F wave. And
Yes, sir.
then
Yes,
in the later part of diastole, it is known as an atrial kick.
ठीक है मैं फिर
So the
मिलता हूँ
later part of the diastole, that is the prominent A wave, and this prominent A wave is the atrial wave. And then the
yes.
closure line is CD. CD is the closure line, you see.
Okay, okay,
The
sir.
systole is from the QRS to the T wave with the seeding line. So this is all diastolic waves, and this is the systolic wave, CD. You see,
Yes,
this
sir.
is the systole is from QRS. So just when you know the hemodynamics and the Doppler, you'll again understand it. Don't worry.
Okay, sir. Thank you. Thank you, sir. Thank you.
So now we come to the after diagnosis, we come to assessment of severity. Now, as I told you, a semi-quantitative gives you some idea. 2D echo gives you a semi-quantitative idea of the severity. Now, for example, you have just to get example, you have read aortic stenosis last time. Now, see this is a parasternal long axis here. You see highly calcified aortic wall, correct? Very poorly opening. There is LVH. So this 2D echo indicates that possibly we are dealing with a severe aortic stenosis. But if your further study does not support it, that means there is something wrong in your calculation. So this just gives you an idea that we are dealing with possibly a severe aortic stenosis because of this thing. Clear? You see calcification, poorly opening, and LVH. LVH again, a sign of LVH is because of a pressure overload or so. Again, you see you see again significant LVH and the poor opening of the aortic wall and concepts. So just to show you that the 2D echo, don't neglect the 2D echo. Now you see a mitral stenosis, you see there is a thickening of the cusp at the apex, good opening, paradoxical motion. But if you see here and you see a doming, but here you see this is a calcified wall. So that means, and there is usually no doming. A doming is a sign of mobility, but here the wall is calcified. So if you see this wall, it gives us an indication that the stenosis is severe. So that when you do a calculation by Doppler or mitral wall area or something, it should match. That is why your clinical echo and Doppler should match each other. So now again you see that the again restricted opening calcification, and because increased echogenicity means a fibrosis or the calcification, and usually there is no doming because there is a less mobility. And but the most important is the mitral wall area. So this is semi-quant. I'm giving you few examples to get an idea that yes, it is the quantitative, possibly this. But the most quantitative is three things: a planimetry and a pressure half time. At least the quantity equation you can forget for the time being. On the planimetry, again, what I've written, hands-on. There's no point in telling you theory. This will be on hands-on you will be doing. But remember, it is the most accurate method for estimating severity this is done at the short axis view, zoomed view, and include commissures when they are open. So this I've written that just to show you that this you can measure the vital wall area, but associated with a hands-on, but in a short axis view. But so that there are this is again to tell you that optimize that this all will be better understood by you during a live demonstration also. But that is why I always write that practice, practice, practice. In your normal day-to-day working, whether it's a mitral stenosis or not, always try to measure a mitral wall area so that you know from where to measure. Come up to the papillary muscle level, from papillary muscle go to the mitral wall level, again stop it. Then atrial fibrillation, several measurements and this thing. But the main important thing is that from a short axis view, again that will be better understood by you either on a hands-on or during a thing where we give this importance right from the very first or the second day. Now see, the 3D echo, of course, is the most important. It is much more than better than the 2D echo, but because it will not be available with you, it tells you the whole about commissure, subvalvular, and give you the best idea of the mitral wall area. So it is the sort of a gold standard. So one is a pressure half time. A pressure half time, just a definition, forget about it. The time required by the pressure gradient to fall to half of the value. Now remember one thing only, in a severe mitral stenosis, the LA pressure is significantly increased as compared to LV. So it takes a longer time to have a gradient fall to half the time because you see the gradients are very high. But forget about this. Only remember this, a mitral wall area 220 by a pressure half time. Your duty is to get a good mitral Doppler. This is the mitral Doppler. Again, here we don't call an EF slope. So this is E wave, rapidly filling opening. This is deceleration slope. This is A wave. Again, what you have been seeing. So your duty is to have a good mitral Doppler, trace the deceleration slope, and that will give you the mitral wall area automatically. For example, you see here the pressure half time was what 182, 220 by 182 give you an area of 1.2 centimeters square. So your job is to go to an apical 4-chamber view, go parallel to the Doppler beam with the help of a color flow mapping, put a CW or depend anything you want to put, but especially CW have a good Doppler recording. And when you have got a good Doppler recording, you measure the deceleration slope, which in M mode is known as an EL slope, and this gives you automatically the mitral wall area. So this is the advantage of this technique is that it's a very simple technique. It doesn't take more than few seconds, and it is reproducible, very easy to do. It has got some limitations, but it is very easy to do, fairly good reproducibility, and you can get it within few minutes or so. So aim is to get this. Now I will only tell you those problems which you will feel into your day-to-day work, not otherwise or so. What we feel in our day-to-day work, it is sinus tachycardia. As the sinus, the best rate, I would always say below 100. As long as it is 70, 80 or so, it is the best rate to do any Doppler study. Now, when there is sinus tachycardia, what happens? You see, there is no slope. We want a slope like this. So here you cannot do anything because there is a marked sinus tachycardia. So what we do, and you'll feel it anytime you feel it more than 110, 120, you feel the same problem. Forget all other techniques. What we do is we send the patient, ask the patient to take a small dose of beta blocker like a beta lock or something in the night. Again, take the next dose 2 hours before coming to the lab. So by this, automatically the heart rate will settle down. giving them reassurance, giving them sedatives and all this. Now, suppose the patient is an outstation, then is the problem. In outstation, then they have to wait for quite some time. Then you give a sort of a rapid short-acting one and see. Otherwise, most of these patients, we tell them also that there will be no charges again. So that is the way you had when your only reassurance and giving a beta blocker, one in the night and one 2 hours before in the morning, because that's the time it takes to act maximally. And then we get what is known as this slope, and it is easy to measure this deceleration slope. Now, so here you see, we have measured deceleration slope and we have got the mitral valve area. We have taken two, the pressure of time was 120, 220 by 120 is give you the 1.8 or so. So that is, remember, any time, now again you see this is E wave, this is M mode ka F wave, and this is A wave. Same thing. So that is how you do a pressure half time. Second is a very common problem we face is a atrial fibrillation. Because atrial fibrillation is very common in our country in case of mitral stenosis. So in your what happens that in atrial fibrillation, your complexes are very rapid, irregular or so. So what happens that you see like this? You cannot do anything, you cannot do anything, you cannot do anything because they are irregular. So what we do, you go on recording. At one stage, in every case you do, you'll suddenly get a recording with a wide diastolic slope. Just freeze it and do it. What we do, we keep recording with one finger on the freeze button. As soon as we get a Doppler with a wide slope, we do the measure. For example, here, none of the things could be measured. But here we can see again, we measure the pressure half time was 199. 220 by 119 is 1.1 meter, 1.1 centimeter square. And then you can trace it. By tracing it, you can get a mean and p gradient also. So that is the thing that, and every time, now, although theoretically will say that you have about 5 beats or so, but they should be of an identical rate or so. So here we could have done in here, and we could have done in here and here. But just for a demonstration's sake, again, this is how a pressure half time taken, and this is how a peak and mean gradient is taken. Third thing which you will commonly seen in your day-to-day practice is that you see here there is a normal slope, a good continuous slope, but in some cases what we see is this is known as a bimodal slope. You see, initial slope is very, very rapid. Then mid-diastolic becomes the normal one. Now, we never measure this one because this is known as, now, there are various mechanisms for it which is still not clear depending on the wall thickness, the gradients also. But here, everything we have shown is this is rapid. Now, if you measure here, it gives an area of 2.4 centimeters square. Because what we have done, we have measured here, like this. We have measured here that is 2.4 centimeters square. Then, if we only measure the body and go up to this place, again not, the two. So the ideal is you take the body, go to the back. So we have taken this portion, we have taken this portion now, and we have traced it up to this, like this we have traced. And now we get about 1.4 centimeters square. So again, the heart rate should be relatively slow. And you see this, don't measure here, only measure the mid portion of the Doppler slope and go back, and you see that will be your mitral area. From 2.4, it came down to 1.4. Forget about aortic regurgitation, but that will tell you later on. Here also, we don't want to confuse with physics, but only remember, sometimes after the balloon dilatation has been done, the cardiologist sends immediately for an echo to see mitral valve area. Always take a anatomical mitral valve area and not the pressure half time. But only one thing you remember, why may be difficult for you. So anytime any intervention is done, it takes about 48 to 72 hours to come to the basal level. So during that period, only measure the mitral wall area, not the PST. Now, continue to follow mean gradient. Now you see, so this is one of the guidelines. I'm not going into detail. You can always read it from there. In one of the guidelines, they in variable heart disease, mitral, nowhere there is a gradient written. Mostly they've written mitral wall area, pulmonary artery pressure, and the wall enlargement also. Mostly. So they have not given any significant importance to the gradient also, but mostly this. So now, but if we, so that is why it says, because it varies with heart rate. If today I have done a mean gradient for heart rate at 80, and next somebody does at 810, then so the value will be different. For example, if you see, so because of this, now I'll show you one slide which I did not want to show you. See. So that is why I always tell you that always write the heart rate, because it will vary with the heart rate and a cardiac output. So, but you see here again, we have to put a parallel to this apical view, put a CW Doppler, and you take the mitral Doppler and again trace it, and you'll get the peak, mean, and everything also. So that way it is less, we calculated, not that, but it has got completely less important. This I bought incidentally because whenever we get an incidental case, we just recalled it. So this is the mitral stenosis. You can see two jets going. One jet going toward the transducer is the red color, one jet going away from it on the blue color. That is just out of clinical interest. We may see it once in 2 years or so, but we recalled it. The same thing when you take from an apical view, you see both the jets. The jet which gives the highest velocity should be calculated. So the jet, if suppose they are same, then you can take an average, but if that's quite variable, then you can take an average. Otherwise, you take the jet which goes the highest velocity. That is just out of a clinical sense also. Any clarification?
Good evening, sir.
Yeah.
Sir, in the bimodal diastolic flow, you have shown the reading should be taken in the latter half of the slope. The lower end of the line, you have touched the baseline.
Yeah, that is always there. Whether you take there or no, I'm talking of this one. Say here you don't go up to this place. So what I was saying that if you don't stop here, normally we go up to the base, but here you don't stop. You go up to hit this place, and you for them when you stop here, it gives 2.0 centimeters. When you go right up to the place, it gives about 1.4. Going to the baseline is of course no problem. This side, but this side you have to check where the Doppler beam goes, where the beam goes also.
Sir, in the previous slide where you have done the pressure half time, the lower end of the line, you have not touched the baseline, you have just touched the lower end of the slope.
Which one? Just a minute.
The previous sinus tachycardia or atrial fibrillation.
See, again we have touched it here. I've touched the baseline, you see here.
The one more, sir, previous one.
That depends upon the person. See.
Yes, sir, this one, sir, the back, sir. This is just the back, sir.
So here you can do
yes,
it
yes,
here,
this
but
one.
ultimately it will remain the same. We are tracing the ES slope. We can say you can go up to this, but this is the most important slope. So here you see.
I want need the clarification. Where should the lower end of the slope?
Say lower end depends how to get this thing. Just a minute. Depends upon the now see here we have gone here because
yes,
here the A wave start. whether you go up to here or go to here, no problem. So depends upon the type of the slope. So you can go up to the right up to the base also, no problem. You can go up to the base. So here it will remain. Ultimately, you are measuring this slope, correct?
Okay,
You
sir.
are measuring. So whether you get up to here or you can get up to here, no problem. You can touch the baseline, but ultimately this should be well covered. That is the thing. So you can do it here. Now see, here we have not stopped here. We have gone up to this because it is well up to this here. So you see, it depends upon where the where how does it looks like. Now see, now here you can go up to the because here the A wave starts. So we don't want to. So it will not make much difference. But what we do normally is depending upon the type of slope, we touch up to the baseline, you see here. And it will be there because ultimately you are only, for example, here you also see we have touched the baseline, we have not stopped it here. So if your grace is touched this, you can go up to this place, no problem. There won't be much difference you can see.
Okay, sir.
Any other doubt?
Sir, in case of a VSD or a aortic regurgitation, is it sensible to go for a pressure half time? Because
No. See, now I did not want to show this. Now see, this is a aortic regurgitation, correct?
sir,
So what happened that the LV is filled up from two sources. You see, this is the pressure half time of so. So depend now once this is the pressure of time you measure the difference between LA and LV pressure, correct? So now when the LV is being filled up by two sources, correct? Then it goes, then that means the LV pressure increases rapidly because it is the filled up by both aorta and the mitral wall. So the pressure after will be shortened. So because it depends upon the rate at which the pressure almost come to half of the baseline, no matter how quickly they try to sort of I'll show you here. Oh. So again you see tachycardia. Here the heart rate, it is not a good tracing. Here the mean gradient is 13. Post beta log it came up to 5. So that is why we say we have to do a heart rate variability. Now see, the rate at which the falling LV and increasing LV diastolic pressure comes into equilibrium. So now take this. Now, so this will come equilibrium more this side. Why now the LV pressure is increased? Why? It is coming blood from both aorta and mitral wall. So the pressure half time will be shortened. And when the pressure half time will be shortened, the area will be more. So that in these cases, we only take a mitral wall area, not a pressure half time. The same thing there you see. Now you see this aorta. If this LB is getting filled from aorta and from the mitral wall, its pressure increases. So when its pressure increases, it comes closer to the LA quickly, so the pressure of time is reduced. So we don't take a pressure of time. Similarly, there are many other situations will be tell you. Any other question? First of all, any other clarification?
Yes, sir. Sir, please
Ah.
elaborate more on taking average of 5 cycles in case of atrial fibrillation.
Say something is theoretical, something is practical. Now, if either you take 5 beats which are almost at the same heart rate, so that means you have to take so that is sometimes very difficult. It is you take any Doppler normal in sinus rhythm. If you take a velocity, all three velocities will be different. That is why we always tell that in a sinus rhythm, take an average of 3. any Doppler you take, you did the unless the patient is holding breath. As we told you, in any Doppler, the patient should be holding a breath. Otherwise, and then you see slight variation, then you take an average. In atrial fibrillation, they say 5 to 10 beats, but sometimes it is very difficult unless you take one beat, then search for another beat with the same heart rate. Because if the heart rate is different, then the values will be different. So that is theoretically they say that it is 5 beats, but if you ask practically, we take about 2 to 3 beats and take an average also. In atrial fibrillation, in any paper you read in the world literature, they always exclude atrial fibrillation as one of the criteria for elimination in the study. So that is the thing also. But so that is why you have to take everything in picture. Don't go only by this.
So which
Now,
what
the aortic, the mitral wall area will also differ. Sometimes it is beating strongly, sometimes beating strongly. So you have to take at least about 2, 3 areas at a different levels also. So there is always a variability in these cases.
so for gradients, what should we do? I mean, how to choose the beat or the largest flow wave should we choose, or how to choose for measuring the gradient if not average of 5?
What?
So, which flow wave, mitral flow wave, should we choose to measure the gradients, sir? How to
For
choose?
gradient, if you have to measure the peak gradient, you take tall P waves or so. Otherwise, you have to trace it. You see, when you trace it, then you get the gradient. If you want to take only peak gradient, which is of no value, then you only take this is a peak gradient. If
So
you
in
want
case
to
of
get a gradient, they use planimeter. That you get a gradient. So
in case of
your
AF,
eh?
in case of atrial fibrillation,
In atrial fibrillation, I told you. Yes, see, in atrial fibrillation, take the widest slope. You see, take the widest slope and then you measure here. And again, we have measured this gradient. But the more thing is in an area. So again, you see, same thing. Remember, a pressure of time is virtually M mode, here slope. Here it's on a deceleration slope. And for peak and mean gradients, always planimeter the envelope or so. So that is why now here we could have done 2 because they're almost the same. So that is how we measure the gradients. Any doubt about gradients?
okay, sir. Okay.
So your job is to get a good Doppler envelope. Rest is there, and you see the more stress is on aortic wall area. That is why we told you that mitral wall way. That is why we told you that always practice. Now remember one thing. This is not connected with our lecture also. Always practice in your daily life a calculation of a stroke volume. Dr. Gupta must have told you last time how much the stroke volume measures in cases of aortic stenosis. No, a stroke volume, I've written boldly practice, is a cross-sectional area multiplied by velocity. And the cross-sectional area is diameter square into 0.785. For example, you have taken a diameter in a parasternal long axis view, square it into 0.785 give a cross-sectional area, and the velocity is converted by a LVOT VTI. So the stroke volume is VTI of the LVOT and cross-sectional area. So you see here, now this is parasternal long axis view. This is a LVOT. LVOT is always formed between the mitral valve and interventricular septum. You measure the diameter about 2-3 times. Now, diameter square into 0.785 gives you the cross-sectional area. You take an LVOT, trace it. This gives you the VTI. Multiplication of the two gives you stroke volume. This will help you in many cases. Any doubt? And this will be stressed upon your on your workshop and hands-on training to calculate this. Now see, this is the LVOT. This is the LVOT. LVOT, in any case, it is known as the LV outflow tract. Every chamber has got an inflow and outflow tract. Inflow from where the blood enters and outflow where it goes. And it is, you see, it is formed between the mitral wall inferior interventricular septum. So you place a pulse volume, pulse septal, pulse PW, because a pulse Doppler, we want to study a particular structure of LVOT. So put a pulse Doppler here and go on moving up and down till you get a good Doppler envelope. So from here, usually it is in the middle of the position also. For example, if you are too far away, you get a low velocity. If you are too close, you get a high velocity. So usually it is the center of this, and you get it. So always practice. Now I've just written why. I won't go into detail. There is also a condition of the low flow, low gradient, severe MS. You might have been told low flow, low gradient, severe aortic stenosis. You might have been told, I don't know. So you see, to practice always LVOT, because that will help you, but that is also a, so this also practice in your case also. So remember, all these, wherever I have written practice, you note it and check during the hands-on. So this was this, you see severity stenosis, heart rate 60 and 80. See here. See, that was the time which is known as a pre-ACC AHA. We used to give an importance to the mean gradient, just to show that as the severity of the mitral stenosis increases, the gradients also increase. So that we are giving there, but now we are giving an importance to area and the pulmonary artery pressure. According to them, a severe mitral stenosis is below 1.5 and very severe is below 1.0. Now, problem is that many of the cardiologists may not be knowing about this classification. So suppose a patient is having 1.2 or 1.3 and we write a severe mitral stenosis, they will say that since when 1.3 has become severe. So we always write as per ACC AHA criteria, this falls into this. So previously below 1 centimeter was known as a severe and very severe. Now they call it very severe because 1.0. So do you remember? Basically now they go by area also. More than 1.5 is mild, 1.5 is severe, and no, both this one more than 1.5 to 2.0 moderate, and this is severe, this is very severe. So this is there. So we still, many of them still want a gradient. So we still record a gradient. So otherwise they say that we have done a mitral stenosis, not recorded the gradient. So to avoid any problem, we always record a gradient and also the pulmonary artery pressure. Any clarification? I am giving you too much of time for any clarifications.
Priya, ask your question.
Sir, I just wanted to know CW or PW, which one is correct to take a PhD and gradient, sir?
I told you that the first two lectures are the basis of every lecture they found this. So आप लोग लगता है first two lectures नहीं पढ़े हैं. As we told you, all diseased flow should be CW Doppler. All normal flow pulse Doppler. And if you want to study a particular area, for example, in LVOT, a CW will record the whole structures according to the whole Doppler D. So that is the CW. So if you want only a particular place to be encouraged, suppose you want to the normal mitral wall, put a pulse Doppler. All these normal flows by pulse Doppler, all disease flows by CW Doppler. Suppose there is a very mild mitral stenosis, and you see that by a, and you must have heard, you must have forgotten what we told you, aliasing. If you put a pulse Doppler, there will be aliasing. If you find that it's a very mild mitral stenosis, you can put a pulse Doppler at the tip of the mitral leaflet where the color flow. Otherwise, it is a CW. Any clarification? Spend some time to read, otherwise, fayda kya? These questions should not have been asked today. So, pulse Doppler, low velocity, normal flow at a particular site if you want to examine. Say pulmonary vein, pulse Doppler, hepatic vein, anything which you want specifically, CW or disease flow. Now we come to complication. We have discussed all these things also. Now we come to basic complications. I'll only show you the images. Now you see this is the parasternal long axis view. This smoke is known as the spontaneous contrast echo. Why this occurs is it is mostly found in patients of atrial fibrillation flutter when there is a low flow state of the constituents of blood, very low flow, and the ultra beam strikes against it, they produce this smoke known as the spontaneous contrast echo. Can you see this spontaneous contrast echo? Can you see it or not? You see, whenever you see a spontaneous contrast echo, always look an LA thrombus. There can never be a thrombus usually before without a contrast echo. So this is always see a, you can see a doming of the leaflet and you see this is smoke. Smoke can be seen anywhere. Now see, this is an ischemic heart disease patient, you see. Very poor LV function, you can see a smoke. Very fine smoke which is going at this spontaneous contrast echo. This is again because of very low flow. Now it is because of a very poor LV function that it is collecting. In mitral stenosis, it was because of an atrial fibrillation with a multiple thing. Now again you see mitral stenosis, there is a spontaneous contrast echo, and there is a large layered thrombus in the left atrium. So whenever there is an atrial fibrillation or so, or whenever you see a spontaneous contrast echo, look for an atrial thrombus. You see there is a large left atrial thrombus. You see here, multiple thrombi. Again, you see spontaneous, this is a transesophageal echo. You see a multiple thrombi, and you can see a spontaneous contrast echo. So just to tell you that various types of a spontaneous contrast echo, then the clots can be seen. Here you see a large thrombus with a spontaneous contrast echo coming and hitting the mitral wall. This is a sort of transesophageal echo, but you see. So just to show you that the thrombus can be seen, but usually there is a spontaneous contrast echo. So always look for this. This is again hands-on. There's no point in telling you on verbally. This is from a short axis view, and you see this is short axis view, aorta, right atrium. L is always behind the aorta. That's a finger-like projection, a very clear finger-like projection. The transesophageal echo is the best method to see for an LA thrombus. Here it is, you see very clear. But sometimes if you are lucky, you can see a thrombus in the left atrial appendage with a spontaneous contrast echo. You see how it is moving like this. Again, you see a left atrial appendage. So you see, mitral stenosis, typical doming, thickening of the leaflet, moving toward each other. This is the modified apical view, left atrium, right atrium, and you can see an atrial septal defect from LA to RA. So this is known as combination of mitral stenosis plus ASD, known as Lutem-Barker syndrome. Huh. So previously it was given a different definition, but now any form of a congenital or an acquired ASD, any form, which is good. For example, this patient underwent a mitral valvotomy, and you see there was a large ASD because you have to go through the atrial septum into the ventricles to open the mitral valve. So this is known as this. So any form of mitral stenosis, any form of a significant this is known as a Lutem-Barker syndrome. It's just a common thing also. Now, I think no doubt about any of these. You all know how to calculate PAP, pulmonary artery pressure. तो पढ़ाया गया है कि नहीं? हैं? Anybody say yes or no?
Yes, sir. Across the tricuspid.
मतलब you have been taught. So I won't go into detail, but take all relevant views. As I told you, you get the maximum velocity. The maximum velocity is converted into gradients. So you take RV inflow view, short axis view, apical view, subcostal view, whichever view in which the tricuspid wall you are parallel to it, record for the velocity or so. And then why? Because when there is a pulmonary artery hypertension, all the load is on right ventricle, as I told you in first slide. So the tricuspid annulus increases in size from this thing TR. I just want to show you two things, again, practical things also. Now you see, this was a case, short axis view, pulmonary wall, pulmonary artery, LA, tricuspid wall, and you see, wherever there is a flow into the LA, there is a mitral regurgitation. I've written now CW versus PW. Now, if you put a CW here, it will pick up both the tricuspid and the mitral and the MR jet. You see, because it has to pick up, and that all your calculation will be wrong because MR jet is a very high velocity flow. So normally what we do, we reduce the sector angle. Now we have cut the MR, we have only taken this MR, only taking this a TR, and we can calculate the velocity. Now here, purposely we have whitened the sector angle of the color flow to include both. And a CW will measure all along this axis also. So you cut it also. Now again you see another patient, you see mitral regurgitation, tricuspid regurgitation, both directed towards each other. And this is a still view. Now, if you take TR jet, it will strike against this mitral jet. So what we use to take other scan planes where we are not able to see the MR and reduce the CFM color flow bandwidth. Suppose you take an RV inflow view or a subcostal view, which you can avoid MR or this. But just to tell you that this is the problem of a CW. And here you see the velocity of the mitral and was about 90 and PA pressure about 33. If you take a CW Doppler, it will again be a problem there. This. Any clarification? अभी तुम ज्यादा गए नहीं तो उसमें क्लैरिफिकेशन नहीं है कि बाद में आप. Lastly, importance of commissures. Always define the commissures for 2-3 reasons. Number one, as I told you, commissure, it will be on hands-on. A commissure will tell you whether you are dealing with a rheumatic etiology or not. A fused commissure is a good for a balloon valvotomy because in balloon valvotomy we split the commissures. When you split the commissures, then everything opens well. For example, this means either the patient had undergone a balloon valvotomy or they are unfit for a balloon dilatation. So that is why it is always fit to see this. For example, you have written hands-on, you see. The short X-ray, you see this is the medial commissure which is open. This is the lateral commissure which is open. So if you have to measure the mitral wall area, you include the commissures. Again, we always want to see that this is a calcified commissure, which is very bad for a BMB. Also, you can see a calcification of the commissures. Now see, this was the overconfident cardiologist who did a BMB in these cases and they produced a rupture of the anterior mitral leaflet. You say there is a tear in the anterior mitral leaflet producing a severe mitral regurgitation. So he relieved one disease but gave another disease. You see there is a rupture of the anterior mitral leaflet because that was a calcified mitral aneurysm that produces severe MR. This again hands-on. This is your and this is again your Wilkinson score, again hands-on. So because there is no point in giving you theoretical thing when you can't understand. We'll show you mobility, thickness, and everything also. Then stress echo, I won't go into much detail. When there is a mismatch between this, I think have you read stress echo or not? Okay, we'll avoid it till you see. So the thing is, we want to suppose the patient is symptomatic, whether it is severe stenosis, COPD, obesity, or poor conditioning to exercise, anything you want to see. See here, this was a 53-year-old obese lady with MS and DAOE. Dystonia aggression. Reason for symptoms, the mean was only 5. After exercise, the mean was about 20. So increase by about 20 millimeters or so. So these are just symptoms. So now when you report, you have to tell the cardiologist the type of valvular thickening. If it is calcified, he will not do a BMB. Type of commissures, degree of MR, mild, moderate, severe, subvalvular apparatus, LA or appendix clot, that will be by T, all other valvular diseases. Suppose the patient has got other valvular diseases, then of course the treatment is surgery. Now, so finally, to revise, what is the review of the practical approach? This is a parasternal long view. We see 3 things in this view. Number 1, what we see is number 1, what is the type of the thickening of the mitral leaflets? Number 1. Number 2, besides spontaneous contrast echo, is there any LA thrombus? And number 3, a severity of this disease and any other disease also, any aortic valve also. So remember basic 3 things: seeing the detail of the mitral leaflet, calcification, and the presence of LA thrombus, and what is known as which I will tell you just now. What is the separation index, the mitral separation index? The more severe the stenosis, the lesser will be the opening. If it is more than 6 to 8 millimeter, that is severe. So this here just this is only for a clinical interest, just to show that whatever you recorded in the 2D can be seen in mitral wall. You can see a spontaneous contrast echo. So 3 things you see here. Now this is how we do a mitral wall. Now in a short access view, you see for again about 3 things. Number 1, a mitral wall area, the type of commissures, presence of a LA clot. So parasternal long axis view, three things. A short axis view, three things you see. Apical view, again three things. The total, you see the mitral wall area, you see. Now here you see, if you take up to the baseline, it goes right up to this place. It depends. The more the steeper the slope, then you can go here. If you take it here, it will go your this will go right up to this place. So that is not done. So we have only to see the ear slope. Suppose it is very, very rapid, then we go up to the baseline, but here we go up to the ear. The main thing is to calculate this ear slope again. If you want to go to the baseline, it will go up to this place. That doesn't serve any purpose. So now it should be clear to you, depending on the type of slope, you go where you want to go up to the baseline or sort. Then of course, apical three things again you see. You see the mitral wall, this. So you see again a thrombus, the presence of this thickening also or the gradients. And you see a TRZ again to see for a pulmonary artery hypertension. Now, this is a guideline for beginners. Anatomy and Doppler best view. Domino, wall thickness, pliability, parasternal long axis view. You have to see all the views, but I'm just giving an example. Mitral orifice area, short axis view, and apical by a pressure half time. But this is for this case. Commissure's short axis view. Subvalvular apparatus, parasternal long axis and apical three-chamber view. Doppler studies, CW, apical 4 and 3-chamber views. Pulmonary artery hypertension, multiple views. So you can see anything. So all the views are obtained, but in some views, they give you the best possible information also. Basically, remember, again, I tell you, you have to be as parallel to the flow as possible. See in which view, what I told you the first day, in which view this valve is seen, am I parallel to the flow? Just if you measure these basic principles, then you will not forget also. So when you report mitral stenosis, there is the same thing what I told you. Anatomical appearance, severity of stenosis, MR, the same thing what I told you. You have to give in a full information so that whether the patient is fit for balloon or not. Before we go to the tricuspid valve, the few slides, any clarification? Either not clear or completely clear. So please read. Take advantage of the course. So I've given you 5 examples of a clarifications. Now, last few slides about tricuspid stenosis. Remember, main cause, once I told you that scan all the walls. That means mitral, aortic, and everything, tricuspid. And especially tricuspid valve. Always, when you are in apical view, always see for a turbulence across the tricuspid valve. So the main cause is rheumatic heart disease. There may be many other causes in which you are not that much involved. The rheumatic heart disease here. And a tumor like a atrial myxoma. For example, here you see, now this is the right atrial myxoma. And when we did, you see a turbulence across tricuspid valve. That is known as a functional tricuspid stenosis. You see, when it goes into the right ventricle through the tricuspid valve, it produces a sort of turbulence and the velocity will increase. And once you remove this tumor, this functional tricuspid stenosis will disappear. And then, of course, the same thing. Remember, all right-sided velocities should be checked in end expiration. During inspiration, the flow into the RV increases through the RA. So always remember all right-sided pressures, whether it is a tricuspid stenosis, whether it is a pulmonary hypertension, should be done in a expiration or so. Then normal velocities mean less than 2. Severe means the more increase the velocity. Then again, the RA will increase in size because of the pressure gradient and IVC. Now see, this is mitral stenosis, almost a calcified wall. Now, if we have missed this, so would have missed the tricuspid stenosis. But you see, there is a restricted opening of the tricuspid wall and slightly thickening of the tricuspid wall. And see, both the LA and RA are enlarged. LA because of the mitral stenosis, or RA because of the tricuspid stenosis. You see, and then you see again turbulence across the tricuspid wall and a severe TR, possibly because of a pulmonary hypertension. So every time you see a mitral stenosis or anything, always put a flow across the tricuspid wall and see for any turbulence. And then you can see the various you see severe pulmonary hypertension. Again, you see, now here it is, we have brought up to the baseline, but suppose it would have been like this and there are multiple things, then we couldn't have gone up to this place. It all depends upon the type of the slope. Again, you see, here we have brought up to this. So this is like this or so, no problem. Only thing you have to measure the slope. You can come up to this place, but not go up to the other complex. If you go to the other complex, then it will sort the problem out. Now, last slide. What we call as the White syndrome. This might be too much for you. White syndrome means if you find any unexpected finding, try to explain it also. Any unexpected finding, for example, suppose you are doing any case, you find RVs and large. Why? If you quit this White syndrome, now you say, Mamberly, this patient was now, this tracing was about 17 years back. That was done in 2008. So that you are the imaging is like this. Now you see, the patient was referred as a mild mitral stenosis. You can see the everything you see. But what struck us was that the IBS is thickened. In your day-to-day practice, there will be only 3 to 4 causes of a LVH. In your daily practice, number 1, hypertension. Number 2, aortic stenosis. Number 3, hypertrophic cardiomyopathy. Number 4, physiological. Well, there may be many other causes, but you will find this in most common in your cases. So now you see, why was this thickening? So the patient was not hypertensive. So this was a sort of a leading thing. Again, I told you that 17 years back. Then we again went to now you see, we again went and then we found that there is a doming of the aortic wall, which we had possibly did not give that much importance because of some imaging or something at that time. But when we saw the LVS, we saw, you see, the IVS is significantly thickened. Mitral was doming and there's a doming of the aortic cusp. So that gave us a diagnosis that the patient should be having an aortic stenosis. Then the same principle that examine all the walls. Now you see, when we went to the apical view, we found that there is a tricuspid stenosis, a turbulence across the tricuspid wall, and there of course the mitral wall, the thickening, and you see this. Again to this tricuspid wall, again you see turbulence and this. And this was the aortic wall. 3-chamber view, turbulence and AR. With a gradient of almost about 145 and 104 gradient. So the final diagnosis based on just IBS thickening, instead of the mild mitral stenosis, was a critical aortic stenosis, aortic regurgitation, severe tricuspid stenosis, TR with moderate SPH, mild mitral stenosis, moderate mitral regurgitation. Just on one thing. So we have got separate examples of this White syndrome, but we'll let you know later on. Now, anything else you want to know before we close this session? Please read, and revise. There is
Sir,
still time.
Sir, in which condition pressure half time is preferred for assessing the severity of mitral stenosis over the planimetry or any other method?
See, as I told you, planimetry is the universally accepted. Nothing can override the planimetry, and especially a 3D planimetry also. Only when there are a significant imaging limitations, because the 3D also depends upon 2D imaging. When there are a significant limitations also, then you can do a pressure half time. But otherwise, you see, the pressure half time is a very supportive thing also. It definitely supports. Now, for example, I did not show you that case of a subvalvular mitral stenosis because it's too early for you to see. That will be shown at a later time, but nothing to beat that. And again, always try to have a correlation of everything. It's the 2D and the pressure of time will not be exactly the same. There will be some variation. As I told you, the limitations of the pressure of time. Similarly, limitations of the mitral valve. If you say, when do you want to do a pressure of time? When the imaging is very poor. Say suppose there is a COPD, you can't see a good COPD, you can't see a good short axis view. If there is a very highly deformed and calcified aortic wall, a mitral wall, you can't do a pressure of this. You can't do a mitral wall area. So there are certain conditions in which you cannot do a mitral wall area because either of obesity, COPD, atrial fibrillation, markedly calcified aortic cusp also, mitral cusp also, and lack of your imaging experience. So in these cases, you do a mitral pressure half time. So you do both. But if you ask one question which is more significant, that is a mitral wall area which is not affected by anything.
Thank you, sir.
Sir, please elaborate a little bit on paradoxical.
Pardon me?
So please elaborate on paradoxical doming of the PML you mentioned.
No, there is no paradoxical doming. There is a paradoxical motion. Now
motion.
you see the reason that both the cusps are fused. Say that you see in the commissures, you see both the anterior polyleaflets are fused. So because of the fusion of the cusps, they move towards each other also. So when there is a fusion of the commissures, the restricted motion of the mitral walls occur because they differ at that time. So it is because it is a fusion of the cusps that they move in the same direction. Because they are fused, and that is why you say the posterior leaflet moves toward the anterior leaflet. So which is because of the basic pathophysiology of a commissures, they move towards each other, and that is why they produce a paradoxical motion. So don't say paradoxical doming, say paradoxical motion of the anterior, because as I told you, doming is when a structure goes into the LA and LV. So that is the mitral leaflet. So that is the reason for the doming.
Okay, sir. Thank you, sir. And sir, for calculating mitral valve area by planimetry, if the both commissures are not fused, we have to take the commissures in measuring the area.
Yeah. Then you don't take that because if the commissures are not fused, then you see that. You see. Now here you see they are fused. Here you see you can take it here. Here they are this one is split. So when you take an area, include that also in it. You see. Now so here you see. So when you take an area, you include this into the area also. So it is the splitting also. So you have to see both of this and inform them about splitting. Now suppose you see this. Here balloon valvotomy cannot be done. Because in Valvotomy, they split the commissures. See, here this is one of the ideal case for commissure split. Now here also they can split the medial commissures also. So you have to write the commissures, just write commissures, whether they are any split or not, or whether they are calcified or not. That's all you write.
Okay, sir. Thank you.
Okay, all of you can read and then send us an email. Okay, no more questions?
And sir,
Good.
regarding severity of tricuspid stenosis, I mean, is there a mild, moderate category also? Severity of TS, how you grade severity of?
Yeah, there are a lot of that. So you see, severity is a mean gradient of almost the more the severe stenosis, the greater is the gradient. Area less than 1.0 centimeter square. Marked area and IVC enlargement. Now suppose you find a less gradient. See, the problem is that irrespective what severity the tricuspid stenosis, they have to do something for the tricuspid wall. Because in one sitting, they have to do it slightly the tricuspid. But if suppose it doesn't fall into this criteria, then you call it a moderate or so. So, but usually you see when there is even when there is a severe tricuspid regurgitation, the intervention cardiology, they try to do they do a various intervention procedures in the tricuspid wall. So that is there. So irrespective of that, they will do. They may avoid giving a prosthetic wall in that case, but they may like to do a sort of a placement and do some things also.
Annuloplasty, sir.
Same thing.
Yeah. So basic class is like if you have a severe tricuspid stenosis, that's fine. So anything more than 5 millimeters of millimeters of mercury gradients and less than 1 centimeter square area you call severe tricuspid stenosis. Less than that is progressive. You have to vault them.
Okay. You can read this ACC-AHA criteria of 2014 about this progressive something or so. But I think these are the basic things also.
Okay.
Anybody, any other questions? Madhav, you have still some questions?
No, sir.
They were going on asking in between.
So if there are no more questions, can we call it a day?
Sure, sure.
So thank you very much, sir, for your excellent presentation. And
No, but they should
learn about it, definitely, sir.
They should learn.
So obviously the important issue is learning and spending time with all
Will
these.
will they be shown a sort of a demonstration on?
Yes, sir. We are planning to show a live demonstration for MS. We have already shown AS and TS.
Because that we told them that cases like how to see LA appendage, how to see a mitral wall area can be done, and Commissure, that will be only better understood in a hands-on also.
Sure, sir. Definitely we'll do that, sir.
Okay.
Okay. Thank you very much, sir.
Thank you. Thank you.
Thanks a lot, sir. Thank you.